Ready. Okay. All right, guys, welcome back. We're about to get started with our post-lunch presentation. My name is Yolanda Whitty. I'm clinical pharmacy manager at WellStar North Fulton Medical Center and have been a GASPEN board member since 2014. For in-person attendees, please don't forget to drop off your completed vendor passport to enter our raffle. For our next topic, we'll have 4 speakers. So please hold your questions until the end. I will introduce our first speaker, Dr. Albert Barocas. He is a board-certified surgeon who graduated from Emory School of Medicine and completed residencies at Emory VA and Keesler Medical Center. Following 7 years in the United States Air Force, he was in private surgical practice in New Orleans until Hurricane Katrina in 2005. Simultaneously, from 1988 to 2005, he served as the Vice President of Medical Affairs at Methodist Medical Center, where he was also Medical Director of the Nutrition Support Team. During his time in New Orleans, he was appointed as clinical professor in the surgery departments of LSU and Tulane Schools of Medicine, the Tulane School of Public Health and Tropical Medicine, and assisted in teaching at Xavier University School of Pharmacy. From 2006 to 2018, he was Chief Medical Officer, last serving at WellStar Atlanta Medical Center. Dr. Barocas has been involved in nutrition support for almost 50 years as a practitioner, teacher, mentor, author, presenter, and coach. He was recently recognized by Aspen as the inaugural Aspen Champion Award recipient. He's a charter member of Aspen and currently is the co-chair of Aspen's Value Project. In 1993, he became an honorary member of the American Dietetic Association, now the Academy of Nutrition and Dietetics. Dr. Barocas has 166 publications and 548 presentations to his credit. Welcome.
And thank you for your kind invitation. It's always a pleasure to be among Georgians, if you will. And I am a paid member of the GASPEN group as well. See, this was supposed to work.
Yeah, if you hit enter.
It's not advancing. I mean, I can use it this way, but I was hoping that this, because it was working before. Let's see something. Well, even this is not advancing either. Will it work now? No. Okay, it's working now. Good. By way of disclosure, I have neither a financial nor commercial aspect to disclose, but I have to disclose that I'm neither an ethicist, a researcher, a scientist, a lawyer, or a nutritionist, although I consider myself a dietitian in name only, since I was, as mentioned before, an honorary member of the ADA. I'm a retired clinical administrative individual, so whatever I tell you today, 6 years after retirement, take with a grain of salt, please. I also want to tell you that in this presentation, you're going to see some very busy slides. And I don't want you to dwell too much in trying to read every aspect of it. I did it on purpose so that we can have a more profound discussion at the end. And if we don't have time for that, I will be giving you some reference to contacting me directly. But I wanted to talk a little bit about the 3 eras, both of parental nutrition, as well as the 3 eras that I see in the development of nutrition support teams and where we are currently, and describe the concept of transdisciplinarity or transprofessionalism, as well as discuss a concept that has been close to my heart for almost 30 years, which is called the troubling trichotomy of T3, and how that may impact you and your teams as we go forward. Now, in preparation for this conference, I thought I would try to get as much information that was up to date as possible. So last week, as you will recall, Aspen had a webinar on nutrition support teams. And one of the speakers, the main speaker, was Phil Ayers, past president of Aspen and a mentor of Andrew. And so I went to learn something, and lo and behold, found, if this works, and it may take me a little while here. Here we go.
And so again, a lot of
There you go.
different disciplines involved in our
I
nutrition
learned
support
that
teams.
what we were
The
dealing
nice
with
thing
was
about this,
my
within this
article.
paper, they give you definitions
what you're gonna
related
hear
to
today,
teams and interactions of team members. And
just
in 1994, actually, Aspen
to
changed
get
from
this
this
off.
concept of being multidisciplinary to more intradisciplinary. So in a multidisciplinary process, it means you have these different disciplines that are involved in the process. Where you move over more to an interdisciplinary model, these disciplines are interacting, they're communicating, they're collaborating with one another.
Do it this way.
We'll have to stay there.
Oop, no.
That has to stay there because that's the video. We can do this.
In other words, I want to get back to the presentation. Normally, there's an X here. Sorry about that. You know, I'm slow in these things, and just to tell you how slow I am in technology, it takes me about an hour and a half every Sunday to watch 60 Minutes. Anyway, yeah, but you know, I have a couple of other links, and we may have the same problem, but we'll figure it out. Anyway, we have some assessment questions that time may not allow at this time, perhaps during the Q&A period. So I want to go ahead and move on. As it relates to parental nutrition, I think we can talk about the early 60s, mid 60s, when we only had blenderized formulas that were providing through very rigid rubber tubes. And out of the US space program came some very innovative solutions, chemically defined formulas that were translated to the bedside by individuals such as Dr. Henry Randall from Rhode Island, and also improved the delivery with nasoenteric tubes. Subsequently, the seminal work of Dudrick, Wilmore, and colleagues at the University of Pennsylvania brought us, you know, parental nutrition, hyperalimentation, as it was determined. And then there was an explosion of this knowledge throughout the nation, in various institutions, and throughout the world. However, what you may not know is that, like any new technology, it was not well accepted by the rest of the medical community. And so as these pioneers like Blackburn, Bistrian, et cetera, tried to implement and tried to be part of a larger society such as the AMA or the American College of Surgeons, they found no refuge there. And so they created the new society, the American Society for Enteral Nutrition, that was established in '76 and had its first annual meeting in 1977. I think the other era started in 1974, going through the present. And during that time, we were able to demonstrate that through anthropometric and other clinical measures at that time, we could establish a diagnosis of at risk of malnutrition or malnutrition. And from that, a seminal work by Butterworth in 1974 at the University of Alabama, Birmingham, demonstrated that about 30% of patients in the hospital exhibited some form of malnutrition. This is the so-called skeleton in the hospital closet, which unfortunately to this day, we still have the same percentages. And I think it's a challenge for all of us in this room to keep in mind. Obviously, we moved from that to a more, or to a different set of criteria to establish the diagnosis based on inflammatory diseases or the presence there, whether acute or chronic, through the GLIM, the Global Leadership Initiative on Malnutrition, through what you heard earlier today, the nutrition-focused physical exam, and at the same time, improvements in the technology. And here I'm just showing you the Dopphoff tube. Many of you may not be aware, but the Dopphoff tube was developed by Dr. Doby and his surgical resident, Jim Hoffmeister, thus the name Dopphoff. As it relates to nutrition support teams, again, initially in the research realm, if you will, you needed someone that had the discipline of a particular practice, if you will. So the pharmacists had to help the doctor figure out issues with compatibilities, pH, osmolarity, etc. Nurses, of course, would be interested in how the therapy was being monitored or issues regarding infection. The dietitian, of course, always there with the proposed diet, proposed therapy, and then monitoring. And the physician responsible for the underlying disease, how nutrition would apply to that, and of course, access. Formal nutrition support teams of what I call the core for dietitian, nutrition, nurse, pharmacists, and physicians probably started around 1972, 73. There probably were many others. The ones that I was able to identify with the help of Dr. Bruce Bisterin from Harvard is that there was a hyperalimentation group at the Massachusetts General Hospital and then Boston City Hospital. Now, as I said, from 76 to say 94, ASPEN was then founded on the basis of a multidisciplinary team, meaning that now we had not people just working in the lab, but once this became commercially available, that we would have a true team that would see the patients on a daily basis, discuss the case, propose a prescription for the next day, etc. And we have seen the transition from multidisciplinary, which is the concept that ASPEN embraced. In 94, it switched over to interdisciplinary as we came together in committees and planning sessions. And I submit to you that now we are in a phase that is transdisciplinary that we will discuss a little bit further on. And whether we call it a discipline or a profession is a term that is used interchangeably, and we'll talk about that in just a minute. And then a different era started in 1983, as we were discussing at lunch just a few minutes ago. And that was the introduction of the way the hospitals got reimbursed. Prior to that, we had what was called a retrospective payment system. That is, the more you did, the more you got paid. And so that was able to fund full-time nutrition support teams, medical directorships, dedicated nurses, and so on. Unfortunately, we have evolved from that to the prospective system, what we call the DRGs. You know them as diagnostic related groupings. But back then in Southeast Louisiana, we thought the DRGs meant the revenue is gone. So the nutrition support teams have been incorporated in now teams that have evolved, sort of following the model of ASPEN. So we have critical care, trauma, diabetic teams, etc. Again, the difference between a discipline and a profession, discipline is, you know, the chemistry and all that stuff that you studied in undergrad, while the profession is what you're licensed to do right now. But we use the term interchangeably. Throughout the years, as I said, there have been a lot of changes in the way that the United States financed healthcare. But it was this pivotal thing in 1983, down at the bottom, IPPS and DRG, that made the difference. And for those of us that always want to question, why? Why is it so difficult to get this done? Why is this not being approved? Remember the golden rule of healthcare. Whoever has the goal makes the rule. And that's what we have to live under. And so we were challenged, not only in the nutrition support realm, but in other areas, to demonstrate value instead of volume. So there's a bit paradigm shift. And what is value? Value is outcome that are achieved at the same cost or lower cost to deliver those excellent outcomes. We're going to see this slide multiple times today, so I'm not going to dissect it any further than that for now. So as we look at 2024 and retrospectively look at where we were in the 70s, we see that we have formal nutrition support teams with a core four, as you'll hear later on from my three other colleagues here. But also we have the OWAs, other weird arrangements. So you may have an informal team. You may have a team that is only one or two members of the core. You may have virtual teams, and this was popularized during COVID. Or you would see the emergence of these other Aspen-like models where you have health care teams where one of you or two of you are representing the nutritional aspect of it by bringing in the information from the other members of the core four. And I cannot have this discussion without realizing the importance and the impact that advanced professional practitioners have made in this. And these are the individuals that we need to embrace because they are really sort of physician extenders, and they're the ones that we need to educate further. And while there may not be an I in team, remember that there's no success without you. Keep that in mind. Now, briefly, as far as this concept of transdisciplinary, transprofessionalism, as I said before, it functions more on on function rather than form. So while you may be multidisciplinary because you report to a different department chair or a different member of the C-suite, the fact is you come together in committees and teams in an interdisciplinary fashion. I propose that when you work in a transdisciplinary fashion because you try to work at the top of your licensure. And at times, there may not be a dietitian available in your particular area, and it may be the pharmacist who is the most capable at that time to provide that function. And so long as that function is covered both by your institutional privileging or your licensure, you're providing the best optimal nutrition support to your patients. This is also important when there may be drastic changes in the reimbursement of your team. If you see FTE reductions or reassignments. And keep in mind, and we'll talk about this at the end, that increasingly other areas, economics, oil industry, et cetera, are looking more and more at this interprofessional education. Now let's look at teams per se and see what, and I think from what I've read previously, that the teams that are going to be presenting are exhibiting some of these potential factors that maximize the effect of a nutrition support team. Leadership. I'm a very strong proponent that the leadership of the nutrition support team should be a physician. That doesn't mean that that physician is an expert in nutrition, but he's somewhat of a liaison in most hospitals between the medical staff and the nutrition support team and the liaison with administration. And so when you're trying to get some FTEs added, or when you're trying to get funding for a research project or funding for that, it's important to have that individual. And that individual could be the chief of the hospitalist group. But you need somebody that is aware of what you're trying to do, embrace you, and then provide that information. They don't have to be, like I said, experts in nutrition. As far as your obligation as a member, you need to be strategic with meetings. You need to be honest and authentic in your work. And then always have a very specific policy and procedure manual that delineates the various functions so that you can perform in a transdisciplinary, transprofessional fashion. Lastly, and we were talking about this with Allison the other day, is the issue of the changing sphere that what we need in nutrition support, needed it all along as far as members, is commitment and not contribution. And I don't know how many of you are aware of the story of the chicken and the pig that are walking in front of the Acme diner that is providing a special breakfast for ham and eggs for $1.99. The chicken says, look at this, I'm contributing. And the pig admonishes, says, wait a minute, for you it's a contribution, for me it's a lifetime commitment. And so what I want you to do is leave here today. I'm not going to mention the word because I don't want to insult anybody, but leave here today not being a chicken, okay? So how do we maximize our potential? And I usually like to do some of my teaching by using aphorisms. And my kids once threatened that if I didn't make it as a surgeon, I could always be the cookie, the Chinese cookie messenger writer there. But first, in order to be understood, we have to understand. If you're sitting across the desk or across the table with the administrator, he's not going to be interested as to whether you're using soybean oil or fish oil or omega-3 oil. He's interested in finding out what have you done that is in keeping with the mission of the hospital. What have you done in terms of improving that bottom line? What have you done in improving quality scores, patient satisfaction, etc.? You must know the lingo of who you're speaking with. For you to be understood, you have to first understand. Lastly, I have several others, but this probably precedes your birth. And it's going to be another one of my links. How many of you heard the aphorism or advertising, today the pits, tomorrow the wrinkles? I use that to illustrate that you can't do everything at once. You need to focus on one project, get it done, do it well, and then boast about it. Now, let me see if this works. And this is after Sunsweet.
I'll warn you in advance, I'm not going to like your prune.
I see. And why do you say that?
I say that for a very simple reason. I don't like prunes.
And why?
For one thing, prunes are wrinkled, and I don't like wrinkled fruit.
You don't?
No, I don't like wrinkled fruit at all. And then there's the matter of the pits. Disgusting.
Yes.
Well, what do you do with a prune pit once it's in your mouth? There's no way of getting rid of a prune pit gracefully.
I agree. That's why Sunsweet has developed this brand new pitted prune. You see? No pits.
What do you mean, no pits?
I mean no pits. Go ahead, try one.
Oh, well, yes, may as well get it over. No pits.
No pits.
How do they do that?
They do it.
Well, they're very sweet and moist.
Yes. Has Sunsweet managed to change your mind with their brand new pitted prune?
Possibly. They're still rather badly wrinkled, you know.
Today the pits, tomorrow the wrinkles. Sunsweet marches on.
Does retinol really work?
How many of you seen this commercial when you were growing up? 1967. At that time, well, we can go that in the further discussion. But at that time, before it became pitted, mothers were encouraged to give their kids pitted prunes, I mean, the regular prunes for a snack in the afternoon. And that wasn't selling very well. So they came up with this innovative way of doing things. The other thing is, when you're dealing with nutrition support and something that you want to do, again, how does it fit in the overall picture? When I show this to some people, they say, well, what I'm looking at is a little red square. Other people say, no, it's a little red square, but there's a white rectangle, and then there's a blue rectangle. And a lot of them don't get the full picture, which is actually a picture frame with a little square in the center. Now, my previous friend has passed away, Dr. Sarai, said that man who looks at leopard through bamboo pole sees only one spot. Keep that in mind as we move along, because you need to understand the mission of your hospital. You need to understand what your patients need, and you need to be involved as an individual. Why? Because if you're not at the table, likelihood is you're going to be on the menu. And this happened shortly after 1983. And again, remember that it's no success without you. Now, how do you demonstrate value to your colleagues, to other people that are not well-versed in nutrition support, to your administrators, to your insurance companies? It's by providing data. And that data should come from your very own institution, whether it's improved reimbursement and cost savings because of better documentation of malnutrition that then leads to perhaps increasing the morbidity, comorbidity, whether it's major or regular comorbidity, to the underlying diagnosis, which then ups the reimbursement, whether it's decreasing the length of stay in your critical care unit, whether it's decreasing the purchase of particular enteral or parenteral products, etc. A lot of these are summarized, and again, I'm not, because it's so difficult, I'm not going to link you to this, but go to Aspen under the value project that we were co-chairing. You'll see a lot of tools, a lot of templates of how to go about this business. Again, defining and presenting value and looking at the denominator, looking at the aspects of safety, looking at care variability and quality, and then service that is person-centered, family-centered, and employing some of those ethical principles that we're going to talk about with Allison in the next hour, dealing with dignity and respect. Those are key components of that outcome that you're looking for. Patient satisfaction. Denominator, care setting, level of care. Are we able to manage this patient in a lesser acuity unit because we are providing nutrition and early interventions? What is the resource utilization? We're decreasing the rate of infections, et cetera, et cetera. Now, additional items. We talked already about the leader champion, and then we talked about adapting the diagnosis of the nutrition as a medical staff. Let everybody embrace it. Have frequent communications. How many of you, I know that, for instance, I think the Emory Group and other groups have gotten national recognition at Aspen for the best nutrition support teams. How much of that was translated to the Emory campus or to the Midtown campus? How much of that went into the internal literature? You need to toot your horn because no one else will do it. All right. And then learn how to practice the language of the C-suite and improve and look at the opportunities for improved revenue stream. In one case, the pharmacy developed a consultative fee. This is several years ago, that was able to capture some revenue. And remember that it's important not to quote Harvard or Johns Hopkins or the hospital down the street. What is happening in your own hospital? When was the last time that you looked at a year's diagnosis on discharge, and what percentage of those patients have malnutrition? Dr. Gunter and her colleagues did this with Medicare data nationally and found out that only 8% of discharged Medicare patients had a diagnosis of malnutrition. As I stated before, surveys have shown that that figure is about 30%. That means we're not capturing, we're not being honest with what we're dealing with. No wonder we cannot justify our existence. We need to establish institutional annual reports of malnutrition in our hospitals. Embrace the help of the documentation specialist. Teach it the lingo. Remember, in order to be understood, you first must understand. And so I urge you, even if you're a one-person band, as I call it, like we had at Atlanta Medical Center with Dr. Teresa Pounds. She ran the nutrition support team. Lastly, and as by way of introduction of the next lecture, I want to talk about this concept of the turbulent trichotomy, which is basically a conundrum between what can be done technologically, what should be done ethically, and what we must do legally. And sometimes they're in conflict, but they all come together as we try to communicate with patients, as we try to get informed consents, considering ethnic, religious, cultural background, but always working as a transdisciplinary team that acts, acronym for accountability, communications, and transdisciplinary work, and then keeping in mind a patient and family-centered discussion. The future, artificial intelligence is being infiltrated in every aspect of our lives, and so it's infiltrating the era or area of education, among other professions as well. And interesting enough, as you move from that pre-licensure to licensure, from discipline to profession, we're seeing the core competencies of that practice, and the combined effort to do it with other professions requires values, roles, teamwork, and communications. So there's still the three tenets of what I call the T3 or the turbulent dichotomy in existence. I want to close by reminding all of us that the goals of healthcare professionals are to cure sometimes, to treat often, but to comfort always. How are we doing with time? Do we have time for the questions?
Just 5 more minutes.
Okay, well, let's look at the learning assessment question. Question 1, what was the impetus for the establishing of the nutrition support teams? Development of chemically defined enteral formulas, Medicare reimbursement, introduction and implementation of parental nutrition, U.S. government mandate. It was, of course, a new technology that required participation of at least 4 disciplines or professions. Question number 2, nutrition support teams, and select all that apply, must be composed of the core 4, RN, RD, PharmD, MD, DO. Should have a formal policy and procedure manual with specific functions outlined, can be composed of a single individual coordinating with other disciplines, can be virtual. The answer is no need, B, C, and D, because there's not a cookie cutter approach that you can apply. And I think that while we're going to hear some excellent presentations of very formalized teams, think about the fact that about 70%, at least that was an older figure, but a large majority of medicine is practiced in small community hospitals that are not affiliated with large medical centers or university. And so in many cases, it's a one person band. The troubling trichotomy, T3, refers to autonomy, beneficence, not maleficence, technology, ethics, and law, nurses, dietitians, and pharmacists, multidisciplinary, interdisciplinary, or transdisciplinary. And we already said T3 referred to the 3 pillars that can conflict. That's technology, ethics, and law. Value is outcomes achieved over cost to deliver outcomes, length of stay over patient satisfaction, number of discharged patients over profit, number of employees over patient census. The alternative to volume is value, and that's what we have to deal with. I'd like to thank you and leave you with my email. Please feel free to contact me at any time. Be glad to share information with you.
Thank you.
You want me?
Okay.
So I gotta go over here.
So I will quickly introduce our next 3 speakers. Thank you so much, Dr. Barocas. Next up, we have Nathan Scober. He's joining us from City of Hope. And oh, it's Marlene. Okay. All right. Sorry. This is Marlene. She is a long tenured nutrition support dietitian with experience in the acute care, home care, and skilled nursing settings. Following her undergraduate studies in nutritional sciences at Cornell University, she completed a clinical dietetic internship and Master of Medical Science at Emory. She also became a nutrition support dietitian at the newly created nutrition support team at Northside Hospital. She's been an ongoing member of that team for decades, but during an approximate 20-year interval of that time, she became an infusion dietitian for Quorum Home Infusion. She recently took on the role of infusion dietitian for a nutrition consulting group to monitor CPN patients in skilled nursing facilities. Her passion for nutrition support started early on. Marlene was the first group of registered dietitians to take the CNSE exam and has maintained certification ever since. In her spare time, Marlene likes to run races, engage in various fitness activities, travel, bake, and play with her feline family.
Thanks, Yolanda. And we won't say how many decades, okay? Miss Clairol helps a lot. Well, I'm Marlene. I've been at Northside for a lot of years. That goes without saying. I would like to just say thank you to Dr. Barocas for providing us with such an eloquent account of the history of the nutrition support team. And also discussed how our teams have evolved through the years based on the impacts of various types of forces that we've encountered along the way. And what I'd like to do now is transition to talk about some of the teams in the Atlanta area and how we've survived, evolved, and in some cases even grown. So with that being said, here is just a listing of our objectives, and I have nothing to disclose. So As I said, we're talking about nutrition support teams in different settings. Well, I'm here to represent a more traditional setting, the nutrition support team in a community hospital. And as we know, our goal with our nutrition support team is to improve and ensure the highest quality of nutrition support therapy and help to reduce healthcare expenses by reducing complications and unnecessary interventions. So just a brief synopsis of our Northside system of hospitals. We are a nonprofit community healthcare system. We have 5 acute care facilities. And obviously at each of those facilities, we are providing nutrition support therapies to our patients. Only 2 have formal teams, and I'm going to discuss just my perspective from being on the nutrition support team at the Atlanta campus. And so let's look at the birth and evolution of the team at Northside. Now, our evolution or our birth and evolution really reflects or is echoed in the very early literature about the nutrition support team initiation and development. Our team was, well, as Dr. Brokus pointed out, with the history or the need for the team kind of arose through the expansion and development of enteral formulas, the advent of parenteral nutrition, and the recognition of the severity of the hospital malnutrition that was often unrecognized. We saw this initially in more the university settings, university hospital settings, and then it began to trickle down more to the community hospital setting. And clinicians there realized that this knowledge needed to be applied in their acute care facilities. And there was a need for educated and engaged clinicians who could diplomatically bridge the knowledge gaps across the disciplines and help develop standards to provide safe and cost-effective nutrition support. Our team was established between 1981 and 82. Each discipline was under a different department. And we did have a physician director who initially was a nephrologist. And then eventually we had a surgeon who was our director. However, within a year, all of our disciplines except the physician were incorporated into the pharmacy department where all our enteral and parenteral products were dispensed. We were a consult-based service and we were not involved in the initial screening of patients. And our team had to prove our value and our expertise. We very early on realized the importance of networking, recognizing who the key players were in opening doors for us. So not only the dietitians, but in many cases, the nurses were very helpful in helping us to identify the patients who would benefit most from our services. Sadly and oddly enough, the role of the physician director was phased out in less than a decade. And as Dr. Brokus mentioned, part of this was due to changes in the reimbursement setting and then also to some degree, a lack of knowledge and a lack of interest. And this is mentioned in the literature. I'm not just saying that, but that was some of the things that were mentioned in various articles. Our team was credentialed by the hospital to write enteral and parenteral orders under an ordering physician and ultimately per protocol. Our nutrition committee was also phased out due to the lack of need for that committee and really the more self-sufficient nature of the team at our hospital per se. So what were the actual roles of our team members? Well, as we said, we had a pharmacist, a dietitian, and a nurse and a physician. Well, the nurse originally was, and this is going back a long time, but our nurse who originally assisted physicians with central line placement and did the dressing changes on all the CPN patients. And then many of these tasks transitioned to the IV team. Unlike other NSTs at the time, all of our members were cross-trained very early on. So we were what? We were basically a truly transdisciplinary approach to our practice. We did nutrition assessments, provided therapy recommendations, implemented those recommendations, provided ongoing monitoring, and helped to transition to the most physiologic route of nutrition possible. Our teams also monitored HPN patients when our hospital provided home parenteral nutrition. We actually had a home care pharmacy and we did home TPN or home CPN patients. Our team members also provided staff education, assisted with enteral and parenteral formulary development, participated in QI projects, which often led to protocol development, including the earlier initiation of enteral nutrition in critical care, the more appropriate use of parenteral nutrition, and a preferred protocol for enteral nutrition versus parenteral nutrition in hyperemesis gravidarum patients. And if anybody knows much about the Northside Atlanta campus, we were a huge baby hospital. So we had a lot of multiple births. We had a lot of women who had a lot of problems with hyperemesis. And we had several people go home with our home care pharmacy and doing TPN through them. And then, we really tried to shift that paradigm to providing more enteral nutrition to these patients and did so successfully. We also submitted posters to GASPEN, and we were involved in a pre-GASPEN organization known as the Atlanta Nutrition Information Exchange, who I know Dr. Barocas remembered Eric Franco, who was one of our predecessors in the realm of nutrition support. He was very instrumental in developing that. And it was also code name was Annie for the organization. We also served as preceptors for students and residents of various pharmacy, nursing, and nutrition programs. And we instituted the requirement for the CNSC for our dietitians and nurses, and highly recommended it for the pharmacists as well. And as you know, there's the pharmacists could do that exam or the BCNSP. So let's see. And if you, let me go back one here. So in addition, where are we now? Well, unfortunately, we no longer have a nurse on our team. Since 2022, we have not had a nurse. But our team does have a very strong relationship and a great rapport with our IB team, which is also a component of our pharmacy. Some of our key activities, including rounding daily with our critical care units, oncology, and BMT units. We still continue to have pharmacy students and residents, and we're trying to bring on some nutrition students as well. We're involved in quality improvement projects, help with the transition of care from hospital to home for our parenteral and enteral patients. And being knowledgeable about reimbursement is very helpful in that arena. So that's something that everybody should charge themselves with. And as everybody has experienced with the product shortages that we have seen in the past several years, we're involved in how to appropriately manage that. We work on the oral and enteral supplement formulary, which we review every 2 years, provide continuing education, and through our competencies, we try to remain up to date with current practice guidelines and reimbursement concerns. So here's just a quick synopsis of where we were and where we are now. We had the core 4, but now we have primarily our CNSC dietitians and pharmacists, and then that strong collaboration with our IV team. And just quickly, how are we doing on time?
3 minutes.
Okay. Just a quick view of how our daily census has improved with time, and the acuity of our patients has risen and stayed high. So what are the future challenges that we see? Well, obviously staffing and training is an issue for everyone. I know we are currently looking, and if anybody's interested, please let me know. We are currently looking for a nutrition support dietitian. But it's sometimes difficult to find new team members with a passion for nutrition support and have the engagement to take on projects or be involved in professional organizations. And since we're truly transdisciplinary, sometimes that takes a little bit longer to train because not everybody has the expertise in all those three areas. And with technology, well, with the lack of a nutrition support team on all campuses, what we're trying to do is standardize some of our practices and policies and such. And we've been working with our technology, which is very helpful at times, but sometimes can be a bit of a challenge when you're trying to improve your processes and develop your orders, because that can take a little bit longer than you always anticipate. And in community hospital settings, you may not have the opportunity to do as much research, but you still can do a lot of presentations. There's still a lot of impacts that we can have. So the last thing is, what can we do to help the nutrition support team survive, and not only survive, but thrive? Well, there needs to be a call to action, and that needs to be now. We need to, well, some articles suggest that physician leadership is essential to optimize your function and longevity of the team. But bottom line, leadership is the key. Leadership from a number of different places. We need to work within our pharmacy administration at our campus to discover areas where the team can help to assist with cost reduction and help improve patient care, become more integrated into our hospital committees and task forces. And we also need to pursue more opportunities to educate newcomers to this field of expertise, the pharmacists, nurses, dietitians, medical students, APPs. And I can't encourage you enough to get involved in nutrition support organizations like GASPEN and ASPEN. And really don't wait to be asked. Just, if you have an interest, ask yourself, how can I help? How can I get more involved? And I loved how Dr. Broca said, there's no success without you. We need you. We truly need you. And remember, if you're striving to be that clinical expert, you need to be able to back it up. So go forth and do your best. And we need your help. So come along and join us. Thank you.
All right, great. Thank you, Marlene. Okay, now I will introduce Nathan Scober. He is joining us from City of Hope in Noonan, Georgia, where he is the manager of clinical nutrition. Nathan has been with City of Hope and part of the metabolic nutrition support team for just over 11 years. He has published on topics of nutrition and cancer in books, magazines, consensus statements, and research papers, as well as providing several presentations on nutrition support in cancer patients at conferences. Working as a team member on the nutrition support team, he helps to cover feeding tube and parenteral needs of both inpatients and outpatients.
Thank you. And welcome again, everybody. It's a pleasure to be here, humbling to be here with such great presentations so far, and really appreciate everybody's engagement in GASPEN. Thank you for being here. My role today is to come and talk a little bit about our nutrition support team. Again, humbled to be able to come and show off, because nobody else will show off for us, as Dr. Brock has pointed out. Not for myself. I do little since now I'm in management, but the team members at City of Hope, which was formerly Cancer Treatment Centers of America in Noonan, Georgia. So our perspective is a little bit different than the others that you'll hear today, because we focus more on outpatient nutrition support than as inpatient. We do have inpatient. We have a 50-bed hospital with a 5-bed ICU and a 5-bed stem cell unit or cellular therapy area, and med surg and all of those things. But the main focus of our nutrition support team is on the outpatients, supporting all the people that are coming through oncology clinic, getting chemo and radiation and all of those things, and supporting them while they're at home and in infusion. So look forward to talking a little bit about that. I have nothing to disclose. Here's our goals for today. So our history, like I said, previously it was Cancer Treatment Centers of America, and now it's City of Hope over the last couple of years. And it was originally started by Dr. Vashi in 1988, who's based out of Chicago. He's a gastroenterologist by trade. but had a strong interest in supporting cancer patients with advanced endoscopic techniques, making sure that we're getting enough nutrition early. He's done a lot of work in the field since then, presents several times at Aspen, is writing papers and all of those things. So he's been a great advocate for us, and we stand on the shoulders of giants, and Dr. Vashi did a lot of work to support us and integrate us into the fabric of cancer treatment centers and City of Hope, so that they're always looking for how can the nutrition support team work into this. Each site as they develop, so we're a nationwide footprint. So City of Hope is based out of California, but we have sites in Phoenix and Chicago and Atlanta. So as each site was built and developed, they all developed their own nutrition support team. So I'll focus mainly on the Atlanta team, since that's where we're based out of for us. But we are nationwide. And then in Atlanta, we started off in our GI team, as Dr. Vashi was a gastroenterologist, so he got us in with their team. It made a lot of sense for us to be there, as many of the people that are on nutrition support while they're going through oncology treatments have a lot of GI issues. We transitioned to internal medicine because there's also a lot of reasons that people don't eat when they're going through treatments that aren't a plumbing issue. You know, it's not necessarily that they have a problem with their GI tract, but that they have depression, or that there's other things going on, that or their diabetes is out of control, and the nutrition support needs to pair with how we're treating the diabetes so that we can get better outcomes there. So it seemed to work better for us to move our attending up into the internal medicine group. We still work closely with our GI physicians, but our primary attending for the nutrition support team is in internal medicine. And then we've received the Nutrition Team of Distinction in 2014, 2019, and most recently in 2024. So very proud of the accomplishments that the team has been able to do over the years. Why nutrition support? It was a means to standardize care. So in a lot of oncology centers that I know of or have friends in, it's the medical oncologist that's having to do the main lift. We have to ask them, is it time to do tube feedings or TPN? Is it time for an appetite stimulant? That appetite stimulant isn't working or has this contraindication. Can we move it? And then there's all different levels of comfortability with oncologists who are worrying about keeping the cancer under control, all the other things that they have to do. And so in a way to standardize that care, getting it through one nutrition support physician that has comfortability with the literature for nutrition and can do peer-to-peers with the oncologist, so that it's not everybody getting a different standard of care based on their comfortability. So we found a lot of benefit with that. Reducing the workload on those oncology teams, which don't have any shortage of work to do as well. And a means to improve the quality based on having consistent literature updates and comfortability, and having a way to work on challenging cases, those fistula cases that are putting out 5 liters a day of stool. How do we get those taken care of? What other medicines do we do? Having a team to pull around those people so that it's not individuals trying to do the best in their area, but not focusing with the team. There's a high prevalence of malnutrition in oncology patients, so we stay pretty busy. And we're aggressively trying to preserve quality of life, performance status, preventing cachexia development and progression. That's one of the other reasons that we really like the nutrition support team, is that it allows us, the literature is always, don't let it get too far, especially in oncology. Early interventions are better. It's hard to regain when the body's under stress and has systemic inflammation and all of those other things. So treating early is a function of our nutrition support team. So that structure nationwide looks like we have a corporate nutrition support team that all of the sites roll up to. And Dr. Vashi is on there, a corporate pharmacist, Carolyn Lammersfield, who's a dietitian by trade, and Kim Pollard, who's an RN by trade, and several of them CNSCs and FASPEN, and have great resources to pull from a corporate side of things. And then all of us have our own doctors and nurses and pharmacists that we work with at our individual sites as a nutrition support team, and come up with protocols and ideas, and then we roll up into this greater structure. Patient care at Atlanta. So on the outpatient side, the doctor, the internal medicine doctor, and the dietitian see all new consults together. So they're scheduled at the same time together. We go into the room together. We have a discussion about the patient before we go in. And that has helped us to get on the same page, to talk about what the literature says before we go in, as well as not having to play that, well, they didn't tell me that, or they didn't put it that way to me. Some of that back and forth that you get, and the way that the doctors ask questions and the way that the dietitians ask questions, you get more information. So then it just helps us to speed to care, go after what is the actual etiology of whatever the problem is, and coordinate that care. And then we follow up with them. We do all of our appetite stimulants there, bloodless medicine support. So being aggressive with iron and hormone supports and all of those things up there. All of our tube feeding patients and TPN is also managed out of that clinic. And we do clinic managed care for the TPN with the home infusion companies as well. RD is available for urgent care for immediate nutrition problems. So it's very yesterday. They called me up there for a new patient that came from an outside facility who their G-tube had broken down the long ways. And so it was leaking everywhere and they needed it to be changed. And it was going to be a long time for IR. And since we're a destination hospital, they had to travel, catch a flight. So we were trying to get them out as quick as we could. So they called the nutrition support team so that we could come up and do a bedside G-tube exchange to get them onto their flight. So it's nice to be able to justify our needs to the higher ups when you can keep people on schedule and not have to pay for rescheduling flights and all of those things. Monthly review of challenging patients on national nutrition support calls. So if we have one of those things where we can't figure it out ourselves, despite having a transdisciplinary model, let's get even more minds on the problems. And then coordinating with our pharmacists and our RNs to coordinate the care and to use their skills to help us as well. Inpatient, we do have, and it is staffed with a CNSC RD. And then we report up to the hospitalist there as far as the main attending. But since all of those patients will come to outpatient nutrition support, if they're going to discharge or if they're having troubles, then we review it with our attending and internal medicine, and they can always do a peer-to-peer to the hospitalist with the help of the dietitian coordinating that care. Manage all the EN and PN on inpatient, placing the NG tubes with electromagnet support for real-time feedback on placements. Work with pharmacy to confirm all TPN orders every day and attend daily rounds on all the floors. We've had several quality improvement projects. As our populations change by the talent that we have in oncology. So sometimes we're doing more GI, sometimes we're doing more stem cell and all those things, changes how many tubes we have versus TPNs that we're doing. So we've done a couple projects where we converted from custom TPN to premix TPN because we weren't having as much volume. Now we're currently working on getting the malnutrition screening tool built into the outpatient clinic so that on regular intervals, at least quarterly, the MAs are screening patients to develop or to see if they're becoming malnourished and get them into nutrition in a timely basis. Teaching and publications, transdisciplinary wise, the RN, Kim, has done a lot with EN safety and ENFit connector transitions. She's presented nationally and wrote a lot of articles on that. Dr. Vashi has done a lot of presentations both in his organizations and at Aspen. We've been participants in some of the consensus statements and some other publications as well. And then thriving. We offer solutions to our medical team. We're taking the load off of our oncology or our oncologists. So not having to send them a bunch of messages, asking them for refills, asking them for changes, all those things. We go back and we get feedback from them that they enjoy, that they don't have to get into the weeds with all those things so that they can focus on their areas. And so that's been supporting, developing a close bond as a team and enjoying the work we do, continuing to strive and improve using new technology. So like I said, using the bedside electromagnet placements has been a great thing. and then bringing back the trainings that we get to the team so that we're all improving. We also are thriving because we're finding barriers. So if the oncologists were saying there's a reason that they weren't sending them to us, it's that they didn't want us to start something aggressive if they were going to start de-escalating care because there was a lack of other treatments to offer. So we came up with an informed consent where it spells out what are the benefits of nutrition support, what are the limitations of those things, when does it become not helpful when you're at different points in treatment, and it spells out what we can do and what they're willing to do so that we have that going into starting any therapies, which has been helpful. And then collaborating with all the other services makes a good team approach. Challenges, continuing to collect data to the points made previously to continue to justify your existence. You always have to have data points and new data points and thinking about that creatively. And that's a challenge for everybody. Getting staffing for collaborative appointments, going in with the physician, that's always a challenge. That's why there's several of us that can go in. Integrating the MST tool, need to incorporate new technologies like all the AI software for muscle mass. Oncology is a great group for that because most of them already have a CT scan. So getting the AI technology so we can see if people have enough muscle mass is an opportunity for us there. And then variable volumes. And there's my references. Thank you so much.
Thank you, Nate. So now Dr. Vivian Zhao will take the podium. She is a distinguished clinical nutrition support pharmacy specialist too at Emory University Hospital, where she's dedicated 18 years of advancing multidisciplinary nutrition and metabolic support. She is also the program director for the only Aspen endorsed nutrition support pharmacy fellowship program. She's involved in designing and performing clinical research and is a co-investigator on several clinical studies related to specialized nutrition support conducted at Emory. She's an active member of several professional organizations and serves as immediate past GASPEN president. She has published original manuscripts, abstracts, book chapters, and review articles. She has been an invited speaker at national, state, and local scientific and professional meetings.
Well, thank you for the introduction. Well, like Marlene and Nate, I'm here to talk about the nutrition support team at Emory University Hospital, which I've been part of for the last 18 years. This is just the objective that we have seen earlier for your reference. I have nothing to disclose. So the Emory Nutrition Support Team proudly upholds a 45 years legacy of excellence in education, research, and patient care. The team's actually started back in 1979 by Dr. Dean Warren, who's a renowned surgeon, also chairman of the Department of Surgery at Emory. The team always started as the core four: physicians, pharmacists, nurses, and dietitians. All the team members are cross-trained and have full prescribing privilege based on a PNT approved policy. In 1983, the team actually started the first nutrition support pharmacy residency in the nation. The team continued to kind of grow throughout the years with adding new members as the hospital expands from 587 bed now up to 791 bed, of which 154 ICU bed. Just off notes, in 2022, we actually transitioned our residency program into a fellowship program, and which being the first and only program endorsed by Aspen. So let's meet our current team members. Among all the team members, we have over 180 years of practice experience in nutrition support. We have two medical directors, Dr. John Galloway, Dr. Thomas Ziegler, 3 nurses, 2 APP, and 2 clinical dietitians. Besides the 2 medical directors, all members are required to be certified in CNSC. Unless you're new members, once you're fully trained, you will take the exams. No exceptions. Now let's meet our pharmacist team. So we have 3 nutrition support specialists, which we are required to certify with BCNSP, not CNSC, with exception with Rachel, who just finished our residency fellowship program in 2023. So she's not eligible to take the exam, but as soon as she becomes eligible, she will take that. And then we have 1 nutrition support fellow and 2 internal medicine specialists. They only help us to cover weekends and holidays, but they are both trained by our team during the residency program, and they actually got onboarding training prior to getting on that responsibility. Our team started as a full consult service for just Emory University Hospital. But over the year, we actually expand our coverage to 5 other locations. They're close to us. I mean, we just see them remotely, right? But that's an expansion. And among the team member, we provide service for 300, pretty much every day of the year. And again, we do have the PNT approved policy with full order prescribing privilege, and we do review them periodically and update them. On average, we manage about 50 to 90 patients a day among us, of which 30 and 55 are PN patients. And from an outpatient's perspective, we offer home PN management for our endocrinologists, gastroenterologists, oncologists, and surgeon. We collaborate with over 12 home infusion companies across 5 different states. On average, we manage 150 patients Monday through Friday. So we're heavy service. Like any nutrition support team, we faced many challenges over the last 45 years. So I'm not going to go over all of them. I'm just going to highlight the big one. Workload, right? We all know. Our team does a really good job in tracking all those numbers. As you can see, the average monthly consult, just new consult, it have increased by at least 50% since 2006. The average monthly new home TPN discharge educations. If you involve in home PN discharge, you know how lengthy it can be. The number have increased by 6-fold since 1998. Similar thing we see in the outpatient side. The number of outpatient home patients that we manage increased from 31 patients weekly to now 155 weekly. All right, besides increased workload, the pharmacists and also dietitian have increased teaching responsibility. If you're looking at the chart, the 20 years later, our responsibility basically more than doubles. How can we adapt, right? We have this pretty much the same staff. So our team had to learn to be creative so we can work more effectively and more efficiently without compromising patient care. So I'm just going to show some of the initiative that our team have tried. Well, first, during our one of the examples is that during our transition from Cerna to Epic, we actually implemented a standardized order set for PN. But instead of having the standard lab, we actually incorporate all the micronutrient that we order for our patient. So then that improves efficiency, and we don't have to search individual one every single time. And we actually changed the free formatted note to a standardized notes for all team members. So we all have pre-built drop-down options, so improve efficiency, but also help us to better capture malnutrition. From our discharge order set, we actually have pre-built templates to improve efficiency, also prevent transcription error. We even pre-built in some Medicare-related statements to be aligned with their coverage, so then to improve efficiencies and facilitate discharge. In addition, we're trying to, in the last, I would say almost 8 years, we've been participating in the general surgery medical resident orientations monthly, so then we can actually educate the surgeons. This is how our team operate, and then that's what you need when you're trying to send a patient home with TPN. So that's improved efficiency. And recently, one of our nurses has been actually participating in the individual discharge rounding weekly to actually troubleshoot for some of the home discharges and what we need to look out for. And in addition, our team always have a nutrition support committee. Initially was only limited at EUH, and now that we actually have expanded to all the other Emory hospital. And with the Emory Nutrition Support Committee, obviously help us manage shortage, help us streamline communication, updating policy and protocol. And through our residency program and residency fellowship program, we actually can educate through journal club, grand round, or patient case presentation. our team always have resources for our own team member to kind of facilitate cross-training. So back in 1980s, I was actually able to dig out the little handwritten resources that we have for all team members, right? Like handwritten, okay? And then 1998, all the team members actually came together and actually type up a nice handbook and then contribute to all serve as a resource for all team members. Of course, now we'll look at the paper, right? So we have now convert everything online, and then we can now it will not only serve as a resource for our team member, we actually can use it for all our learners, since we do have a lot of learners. From the outpatient side, as you remember, we have a lot of them. So we're trying to standardize laboratory frequency for our home patient. Historically, we check lab weekly, but that become unmanageable. So we actually changed to biweekly, or for some patient, we actually do monthly if we deem safe. We're trying to implement improved standard of practice. So for example, back in the 1980s, for a patient that goes home on TPM, we actually give them a 50-page handbook. That's like a cover of that. And so now we actually streamline it into a printed version as maybe 8 pages, right? Much better than 50. We're trying to establish relationship with outpatient dietitians, so then we can actually facilitate the transitioning patient off PN. We also started to establish patient portals or NSC pool, where the clinical staff, physicians, and patient can send us message directly, and we can respond much quickly than phone call or fax. As you know, we can be only like all the initiative that we implement can only take us so far. So we have to solve the problem, right? Which increase FTE. As you all know, that's not an easy task to ask for more FTE. So here are some of just the evidence that we use to support why we need to expand our service. So back in 2015, actually all the pharmacists are required to use TheraDoc, which is like a clinical intervention thing that we use to document what you do. We were able to use the data to compare the budgeted hour for the 2 full-time nutrition support specialists and compare against the actual hour work based on the national average, right? That's what we find out is that there's almost like 2,500 hour deficit that we work, and which easily covered by our resident or fellow. So that help us to justify why we need to maintain our program. Using the similar TheraDoc data, we actually able to show that our clinical specialists actually document over 200,000 interventions annually, which translate into at least $500,000 in saving, which will cover the cost for pharmacy specialists and our residents or fellow. Besides productivity, the team have always been active in looking at cost saving initiative. So back in 1992, some of you might not have been born yet, but our nutrition support nurses actually implemented to placing post-pyloric feeding tube to reduce the use of PN, which you can see it kind of produced a substantial cost saving, which over $370,000. Around the same time, the team decided to eliminate the routine order of pre-albumin. As we should know, pre-albumin is not really a nutrition marker, right? So back then, even though you see it, the saving was only $6,000, not substantial, but technically every penny counts. So if you have many of those projects, it adds up. Another example of cost saving initiative is IV sodium benzoate and sodium phenylacetate, which one vial costs $32,800 for a typical 70-kilo patient to get a full complete treatment. We're talking about $1 million per therapy. It is traditionally indicated for acute hypomania in patients with urea cycling disorder, which is a genetic disorder you don't commonly see. But in 2015, there were some requests in off-label use for refractory idiopathic hypomania. Obviously, you don't want to spend $1 million for every patient, right? So our pharmacists work closely with the genetics department. Suggested to use a sodium benzoate bulk powder, which only costs $18 per kilogram. Obviously, the goal was to transition those patients off to oral as safely and quickly as possible. I mean, I don't need to do the math. It's obvious it's a big saving. And the most recent cost-saving initiative is related to trace element. In 2020, the new trace element formulation came out with the increased price. Based on our general practice, most of our patients would require a much higher dose of trace element. And if we continue practice, it will change. We might increase workload with the pharmacy technicians and the pharmacists. So we actually are looking into, okay, providing different options, which will give us the best choice. So we were actually able to pick an option to save up to $227,000 without increasing the workload in pharmacists. So as a team, we don't always just look at saving for just for the member, but overall for considering all team member that might be involved in that process. Besides, cost-saving initiative is not always enough to show your value. So we actually trying to demonstrate our value through research initiative. So one of our co-director, Dr. Ziegler, who is really active in clinical research, we're lucky enough to kind of take part in a lot of his NIH-funded and industry-funded study. And all those studies have been showing FTE support to our pharmacists. And I've been fortunate enough to be involved in 9 out of these studies. As for our residency and fellowship program, research is actually a requirement for them. So through a lot of their project is really help us to will validate our practice and improve patient outcomes. So here's one of the example. As my residence project, I was actually looking at the incidence of collapsing among our home patient, which we found to be high, 8.7 catheter infection per 1,000 catheter days. And from my study, we actually find that the patient discharged home with a PICC line have a much higher risk than Hickman. So we actually work with IR and physicians, we change practice. So patient go home with long-term TPN, they getting a Hickman before they go home. When data will become available to support the use of ethanol lock in home PN patient with a Hickman, so we implement that and to all our home patients. And then we did a follow-up study which show a 19-fold reduction in infection rate. Some of you might know that in 2018, unfortunately, ethanol lock became unavailable because of the FDA patent indications. So our team have to look for alternatives. We turned to sodium citrate lock. As one of Rachel's project, we actually following some of the patient that got sodium citrate lock. As you can see, it is not as effective as ethanol lock, but it still reduced infection rate by about 4-fold comparing to our standard therapy from my original data. So that's every infection you prevent is to prevent readmission. And that also improved patient care. And then another study we did actually 2 of other previous resident, we're basically looking at micronutrient and CRRT. The first study is actually identified there's a high incidence of diamond pyridoxine folic acid deficiency among our PN patient requiring CRRT. So imagine those other patients got no nutrition, they probably have much higher incidence. So based on the literature, and then we work with a nephrologist, we implement a standard micronutrient supplementation protocol. And subsequently, we did a follow-up study, which shows reduced infection, the deficiency rate. And the most recent study we're looking at actually trying to validate our our practice. Historically, our team always prescribed full nutrition in day 1, which is different than the traditional practice, slow titration of calorie and dextrose. However, our study shows that full calorie can be safely provided with aggressive therapy, electrolyte supplementation early on, and there's really no incident of severe electrolyte abnormality. And majority of our patients, refeeding syndrome result within 4 to 5 days. If you look at the literature, refeeding syndrome results usually take about 10 to 14 days. So if you look at it, we technically potential might reduce length of stay by 5 days. So which could be a significant impact. So besides improving the patient outcome for our own PN patients, we also use our expertise to help to development order sets to benefit all hospitalized patients. Those are just some examples. And because we are trying to be, since we're active in research, so obviously we're active in publications and we want to share our knowledge. Here are just a list of some of the publications that the clinical pharmacists have been involved in with Dr. Ziegler. And then Dr. Ziegler have too many publications for me to cite here. And I think this is the slide that most people were interested in, is that we not only show that we improve patient safety, have cost saving, but a lot of time from administrator standpoint, did you bring in any money? So we're able to establish a new revenue stream by hiring a nutrition support APP to help us maximize reimbursement with proper malnutrition documentation. So during our initial proposal, we actually use a formula that's actually available online and using some of the basic CP code that we usually build as for physicians related to nutrition. We did an estimate if we just the APP see 15 patients a day, by the end, after a whole year, the APP will bring in about $244,000. But in fact, when we run the number last, we actually did 5 times more than expected. And hence the reason why we added the second APP that who just started with us recently. So our motto have been recognized, just like Nate's group. We received the Clinical Nutrition Team of Distinction back in 2017 and 2023. And some of our past residents and fellow have been received various Aspen Award. So that kind of reassures me that our training program is working. And some of the challenges, I think some of the speakers have already mentioned. And then one of the big things to me is that I worry about is the lack of nutrition education for all future clinicians. For future direction, I think we would like to continue to do what we are currently doing, but for my wish list is to expand, maybe have APP for outpatient, right? I think that would be a good revenue. And we're actively recruiting a nutrition support physicians fellow because our medical director is getting ready to retire. So they want to train their next generations. And then I will feel like for our home patients and many of our even in general patient on PN, having our own psychiatrist, a social worker would be nice, right? That's all I have. And then I think I'm gonna skip the learning questions. So then that way you guys can have time to ask questions.
All right, thank you. So I'd like to say I'm impressed by what all of you have shared up here. And I think you definitely have made the case for nutrition support teams, just as Dr. Barocas mentioned that we should. I have no questions online. Are there any questions in the room for our speakers? I mean, I understand they did such a great job. I think we're all impressed and hoping to implement some of the things that they have in place. Yes.
One that are not part of, how many of you following this discussion think that you can begin pushing your institution to have one? Is this helpful?
Yeah. Yes, I can see the roadmap. I mean, I definitely got ideas. I'm a clinical pharmacy manager, and so I'm thinking of ways to push things forward. And I think you laid a great plan out, and they demonstrated how they were able to put the best practice in place. So.
Nate, will you help Dr. Barocas put his microphone on? Thank you.
So just so you know, many of our team members from Emory's are here. So if you want to pick their brain, feel free to do so during the break. Okay, they're right there. And then Erin is our past formal NS team member, so you pick their brain.
Brittany's at the top up there too. She's done most of the work with us.
Now, 2 questions did pop up online. The first question is, in the management of refeeding syndrome, do you happen to have a specific protocol for replacements? And I think that's for Vivian, because you.
So we do. So, I mean, we're working on a manuscript right now. So when we're talking about aggressive electrolyte replacements, so for the FOS standpoint, right, that's the marker that we manage it for. In the literature, would just suggested 10 to 15 millimoles per 1,000 calorie. For what we've seen observed from our study, we've actually to 25 millimoles per 1,000 calorie. And for the most part, that is safe, but obviously that depends on patient's renal function. And unfortunately, it's really hard to have a protocol because every patient's different.
This is true. Second question is, have any of the facilities or teams considered advanced practice residencies for dietitians?
Fine.
No, not that I know of.
It looks like it's a no across the teams here, but it sounds like a good idea.
I mean, we haven't looked into it, but I would think funding will be always the issue, right? We are constantly justifying, okay, where'd you get the money, right? So, I mean, obviously that would be kind of from the department, because at least from an Emory standpoint, we are hired by our own department. So we come up with our own funding for that. But I mean, I think it would be a good idea, because I mean, the lack of nutrition support, like specialized nutrition support training in dietary or in any healthcare providers, education, so I think it's important.
Wonderful. Another question?
And of course, I'm a little biased because Vivian definitely helped me transition. I'm one of the newer providers on the team. But the way that I organically found the position was, and I've been at Emory for the last 15 years, I kind of ignorantly thought it was dietitian and pharmacists, didn't realize it was nurses, also part of the team. But it did work out great. Hopefully I'll take that exam in the next couple of months. I've been studying. But I do want to know, is there a succession plan? Because that's what they presented to me when I interviewed with this panel of people, dietitians, nurses, and the PA was there. That was very intimidating, by the way, but it worked out. Uh, do you guys have a succession plan for people that are transitioning to retirement or going to other disciplines or retiring? Do other teams have succession plans? You look out for maybe someone, I know they have fellowships, but other areas, do y'all have succession plans for your team members that are transitioning out?
Well, Rhonda's from our teams. She's actually a transition plan, right? So, I would say, unfortunately, well, from other team, I don't know, because for us, we try to proactively thinking like one of our team member, Therese McNally, has been with the team for 38 years and she's getting ready to retire since we have Rhonda start training now before she go into, and then like I mentioned earlier that we're recruiting the nutrition support physicians fellows so that we can actually train them to take over Dr. Ziegler. So I don't know if other teams sometimes is fortunate enough to be able to have that kind of support and training to have a succession plan.
Not at this time.
Dr.
We need it.
Bashi, who I sang praises about, is training the surgeon to take his succession when he gets ready for retirement. And then in the dietitian world, we're always asking people as they're interviewing if they're interested in nutrition support, we can get them
Mhm.
up into that clinic so they can observe before they go to take tests. So we're always trying to, but it just depends on the discipline. Right.
And I think I know there's a shortage of dietitians right now, and we are definitely looking at our facility for a new nutrition support dietitian. And I think it is really important that we try to pass on the knowledge and experience that we have. And that's why I encourage anyone who's interested, even if you know someone coming up through the ranks who's a student now or an early practitioner, put them in touch with people who are interested in nutrition support and let us help them, foster them, and get them into our ranks, because there's not as many of us than there used to be. And I think we've made the case that you really do need to have more solid clinicians out there doing nutrition support.
It looks like we have one more question. Time for just one.
Okay. This isn't necessarily about the succession plan, but you were talking about how you have a certain number of people on the team that you qualify for one more in FTEs, but like in a perfect world, how many people do you really think should be on the nutrition support team to adequately cover your needs?
That depends on your patient load, right? And also depends on the complexity of your patients. I mean, obviously, if it was talking about certain like community-based hospital where have less complex patient, a short-term PN, you might not need as many team member versus our team would usually have gut failures, fistulas, and then oncology patients that need a lot more complex care, and then home. Then those patients you take a little extra time to manage, then that you would probably need more team member.
So like the ratio is for like if you need more pharmacists versus more RDs versus more nurses, is there like one that you guys have calculated, like a ratio patient to provider?
So the question is related to what would be the ratio, like how many pharmacists, how many dietitian, and how many nurses that we should have, right? It's a really hard because I mean, not all dietitian are into doing nutrition support. So sometimes we actually take what we can get, right? I mean, historically, we always have 2 on each discipline, and then because the one will go on vacation, so we all want to make sure we have at least one discipline covered at all time. But in general, like it's unfortunately there's no way to define what would be the best ratio. And I think is like Dr. Baroka said, it's like every team is different. There's no cookie cutter. You just make what works best for you. I mean, it's also based on your patient's needs. Some patient might need more diet education, maybe having more dietitian would be beneficial, or some patient might need more nursing related care, having more nursing would be beneficial. Is that?
2 points. One, I think at the end of the session, even if you have just one individual, you can make a difference. And Marlene alluded to the fact about networking. One of the things I enjoy the most about Aspen is the fact not only is it multi-professional and interdisciplinary, but we help each other. So it's about picking up the phone and talking to somebody. I'm not sure whether this will answer your question, but a recommendation that I have is befriend someone in the C-suite, in your administrative staff. It may be the CFO, it may be the protege of the CFO, someone that can come to your committee meeting and just see what it is that you do, but then pick their brain. Say, I'm trying to start this. What information do you need to justify the existence in this institution? And you'll see that they're more than willing. That's what I had to do, you know, befriended the administrator, the COO, and so on. And then when we came back from Aspen meetings, if somebody presented a paper, let them know that this was there in the internal communication of the hospital, let them know that the nutrition support team had attended and so presented or not presented, and so on and so forth.
Yeah, so I mean, I definitely echo what Dr. Baraka mentioned, that you network with someone, right? So for example, like Diana from UAB, we're like chatted all the time. Like, I mean, we share information. If you have a complex patient, you can always reach out to experts that you in the field, and then you can get that taken care of. So you're not on your own. So that's the kind of important why you need a network.
All right, awesome. Okay, so our plan is to go ahead